Hi everyone, I'm Dr. Aditi Gupta, and we have our second meeting of the New York City Women's Health Journal Club today. We will be discussing management of acute uterine bleeding, acute abnormal uterine bleeding in reproductive age group women. This is from the ACOG committee opinion, which was reaffirmed last year or year before 2017. I would like to thank everyone who all made it and who are logged in. I have quite a few people here logged in through the Zoom meeting. All right, so let's go forth. And we chose this topic because we get a lot of questions and a lot of confusion regarding how to manage various presentations of abnormal uterine bleeding in reproductive age group women. I've tried to simplify the slides here, and we can go through them one by one, but bear with me, it is a long presentation. So how do you define AUB? Abnormal uterine bleeding is defined as written in the ACOG bulletin, is bleeding from the uterus that is abnormal in regularity, volume, frequency, and duration in the absence of pregnancy. It is acute or sudden in onset, and chronic is defined as onset of more than 6 months. And normal cycle, as per the ACOG practice bulletin for DUB based on 2012, describes a normal cycle as 5 days by 21 days to up to 35 days. How do you evaluate abnormal uterine bleeding? The first thing is you want to evaluate the clinical status. Is the patient hemodynamically stable? Then second step will be causation, looking for the cause. And the third step is management. How do we choose the appropriate treatment? So I'm starting with the causes here. Obviously, all of the causes or any of the causes can lead to the abnormal uterine bleeding pattern. And when we go to the management part, then I'll talk about the clinical hemodynamic stability. But let's start with the etiology. To make it simple, etiology has been differentiated into two parts: structural causes and non-structural causes. The structural causes can be simplified by the acronym PALM, PALM. P is for polyp, A is for adenomyosis, L is for leiomyoma or fibroid, and I've written here submucous and intramural because subserosal do not cause abnormal uterine bleeding. And then M is for malignancy. Continuing into the non-structural causes, which have the acronym COEIN, COEIN. C stands for coagulopathy, O is for ovulatory dysfunction, E for endometrial causes, I is iatrogenic, and N is not yet classified or idiopathic. Pay attention to the ovulatory dysfunction part of it because that is what we see very, very commonly in women of reproductive age group. So how do you begin to assess these patients? The key element is history. You have to get a thorough history because otherwise our management is not going to be accurate and comprehensive. So you want to know the age at the onset. Did it start at puberty? Was it regular for a while and then did it get worse during perimenopausal period or in the middle of the reproductive age group? Because that is going to give you a lot of hints. Are there any previous surgeries? Any previous surgeries that could have led to abnormal uterine bleeding, like previous DNCs or even a myomectomy? Medications, such as is the patient is on any anticoagulants, antiepileptics, but anticoagulants are very important. Over-the-counter supplements. I put this in here because lately we are seeing a lot of women who are taking a lot of over-the-counter supplements, such as high doses of turmeric, garlic, St. John's wort, and all of these things are anticoagulants, and they can cause heavy bleeding and variable bleeding patterns. Um, then you also want to see for a coagulation disorder. So 13 to 20% of women may have a coagulation disorder, such as von Willebrand's, hemophilia, or factor 8 deficiency. I will attach a handout, which is the actual ACOG committee opinion, which has a screening tool of how to um, screen for factor 8 deficiency. The pattern of bleeding. That is very, very important. Again, it's a main part of the history is how is the patient bleeding? When was it really normal? That's my first question to any patient is when was the last time you had a normal period and when did it become abnormal? So was her prior cycle, for example, lasted 5 to 7 days and coming every 25 days? Or is it now that it's 5 to 7 days and 25 days is the gap and it's very heavy? Or is it like 3 days very heavy or 3 days very light and then 45 days is the gap in between the periods? So you always want to get a full history and want to write down in your notes as well as to how long the period is lasting and what's the interval. Um, are there any associated symptoms such as dizziness? A lot of patients will bleed very heavy and will be dizzy in the first 2 days of their period. And then have they had any prior treatment or evaluation? I always ask that question too because a lot of the times they will tell you after you've been down the path that, oh, yeah, by the way, I went 6 months ago somewhere or 3 months ago somewhere and I had a biopsy done. So you can spare her the biopsy if biopsy was already done. I also always ask what happened when the bleeding pattern changed. Were you dieting? Was there any stress? Was there anything else going on in your life that changed? Um, and then I took the liberty of differentiating the history by causes so that you can actually think logically while taking the patient's history and get to a conclusion. So, for a polyp, your history would be menorrhagia or postcoital bleeding or mid cycle bleeding. That's how the patient will present with. Um, Adenomyosis, the patients will have severe dysmenorrhea and dyspareunia and heavy, heavy periods, not responding to pain management very well. Usually it's cyclical bleeding in cases of adenomyosis. And then leiomyoma, it will have heavy periods and sometimes also very frequent periods or bleeding in between periods. And it's usually painless. Then M for malignancy. Malignancy bleeding can present pretty much like anything. It can be either continuous heavy bleeding, not stopping, or it can be bleeding after sex, or it can be very frequent bleeding, or it can be like postmenopausal bleeding. So, as I mentioned here, premenopausal malignancy would be new onset meno or metrorrhagia and postcoital bleeding, and postmenopausal would be just postmenopausal bleeding. Then going into the non-structural causes, coagulopathy. Usually coagulopathy will have usual onset at puberty, unless the patient was started on any anticoagulants due to history of blood clots or some other heart condition, then she may have late onset coagulopathy related heavy periods. Ovulatory dysfunction. This is what we see a lot in our practices, all across this age group pretty much, which includes polycystic ovarian syndrome, obesity, endometriosis. All of that is clubbed under ovulatory dysfunction. Endometrial. Endometrial causes can be, again, hormonal as well as endometriosis. And also, endometrial polyps can kind of be put in there, but this is not structural. So, it's mostly hormonal imbalances and endometriosis. Iatrogenic can be foreign body, surgery, or trauma, and also IUDs and or Nexplanon. That's iatrogenic. And not yet classified, which is none of the above, or idiopathic things that we don't know about. How do you evaluate these patients? So now we get to the hemodynamic stability part of it. So first thing first is, you're in the office or even in the emergency room and you have a patient come in with bleeding. The first thing you want to do is check for vital signs. Make sure she's hemodynamically stable. And if the blood pressure is low or she's tachycardic, then you do orthostatics and make sure the patient is stable. If the patient's not stable, then we need to send her to the emergency room. Or if you're in the emergency room, you would like to start an IV and then start further evaluation. So you're doing a general physical exam, looking for pallor. I'm jumping straight to the genital exam, but I would do just a overall cursory exam after pallor. You want to look at the abdomen, just make sure that she's not doesn't have an acute abdomen. For example, a ruptured ectopic could be presenting to you, and you have no idea what's going on. So, going to the genital exam, the first thing first is inspection. On inspection, take your time doing the inspection, even if it's a quick inspection. You're looking for signs of any trauma. You're looking for signs of any tumors, any malignancy, or any foreign bodies. Then you do a gentle speculum exam. Now we understand that when the patient is bleeding heavy, you may not be able to see a lot during the speculum exam. But the reason it's important is you want to see if the bleeding is coming from inside the os or if it's coming from the surrounding vaginal wall, or it could even be coming from the cervix, like actively bleeding cervical polyp. I had a patient one time who came in with heavy bleeding, and my medical assistants did not want her undressed because she was bleeding heavily. And I put a speculum inside her. There was a huge vaginal tear in the left posterior sulcus, vaginal sulcus, and it just happened from sexual intercourse because she hadn't had sex in a long time and she bled, and the whole posterior vaginal sulcus was bleeding really heavy. So if we had not examined her and just done an ultrasound and given her OCPs or something, we would have completely missed a whole tear that needed suturing. So this is why speculum exam is very important. Next, you go to the bimanual exam. So in a bimanual exam or pelvic exam or digital exam, whatever you want to call it, you want to rule out pregnancy. You want to feel for fibroids, any tumors, any uterine or adnexal masses. So next step would be initial labs. So initial labs, what would you do? I'm going to go to that in the next slide. So I'll talk about that more in detail. First thing first, in this age group, you want to rule out pregnancy. So you do a urine pregnancy test, and also your labs should include beta HCG. Then hemostasis, how do you check for that? Puberty menorrhagia is usually when we check for hemostasis or do the coagulation profile, which should include, again, I have it in the next slide, but you want to rule out von Willebrand's disease in that. Thyroid dysfunction is one of the most common causes, or not most common, but very common causes of irregular bleeding or dysfunctional bleeding in this age group. So thyroid function should be a part of your initial labs. Then PCOS or polycystic ovarian syndrome, which can cause anovulatory hormonal imbalance. So that should be a part of your lab workup, provided you see other signs of PCOS. So we'll get into this step by step. So the initial lab panel, my panel, includes complete blood count, type and screen in case she's pregnant, HCG, TSH, and prolactin. So you want to make sure the patient's not anemic, and the hypothyroidism and hyperprolactinemia go hand in hand, and they both can cause abnormal uterine bleeding. When do you do a PCOS panel? So sometimes it's better to do a PCOS workup along with the initial workup right away, so we don't delay the treatment and have the patient coming back and forth. So if you see signs of obesity, acne, hirsutism, and a prior history of irregular periods, meaning oligomenorrhea or skipping periods, or if there's a prior history of, for example, 3 months amenorrhea, and now she comes to you busy with heavy bleeding, you should do a PCOS panel in addition right away. You also want to check for chlamydia in sexually active women because chlamydia is a known cause of irregular bleeding. However, bear in mind that chlamydia does not cause heavy bleeding. It will cause irregular spotting or postcoital spotting mostly. So in puberty menorrhagia or bleeding disorder suspicion, as I mentioned before, you want to do the above lab work, at least the initial panel, plus you do a prothrombin time and a PTT and von Willebrand factor and fibrinogen factor 8 and ristocetin cofactor assay. For those of you who work out of offices and who do blood draws in the office, just so you know, some of these tests need a frozen specimen, so you may have to send the patient to a lab with a prescription to get these blood tests done. Anemia, if the patient looks unstable, you can add iron, ferritin, and total iron binding capacity at the same time, or you can wait for the hemoglobin results to come back and then add them later on. CMP or comprehensive metabolic profile, I've added it in here in case you're suspecting something, but the polycystic ovarian syndrome panel should have that as well because of the way the PCOS can affect your body, and you want to make sure that her liver function test is normal because some of these patients will need OCP or combination oral contraceptive pills taper, so you want to make sure you have a stable liver function. Imaging. So imaging is key. You cannot skip imaging when you have a patient with abnormal uterine bleeding because you will be surprised at how many things you find. So again, I tried to classify this logically according to the Palm-Cohen system. So by ultrasound for P, you will see a polyp. You can see a polyp very nicely with a high resolution 2D and 3D ultrasound. If you suspect it on 3D ultrasound, the next step would be doing a saline infusion sonogram if you need to, unless the patient needs a DNC hysteroscopy anyway, then you don't need to have the patient go through that saline infusion sonogram. The current 3D sonograms are great. I have attached a slide of in the next slide of endometrial polyp, and it's you can tell right away. So then A for adenomyosis. On imaging, an adenomyotic uterus will have thickened uterine walls. The entire uterus will be symmetrically enlarged, and when you do the 3D imaging or the 3D probe with a patient with adenomyosis, you can tell. I mean, experienced sonographers will be able to tell you right away that it looks like adenomyosis. Then fibroids or leiomyoma. Again, you want to make sure that the fibroid is intramural or mostly submucous, or an intramural with submucous component, because we tend to blame all the fibroids for causing heavy bleeding, and that's not true. And it's really sad because I get a lot of patients who come to me after being through various physicians or themselves believe that, oh my God, I have fibroids, so I have heavy periods and I want my fibroids out. And then I see that they have a 7 centimeter fibroid, which is nowhere near the uterine cavity. It's a subserosal fibroid, and it should have nothing to do with her periods. So, these kind of patients do very well with just medical management of abnormal uterine bleeding. So please remember, all fibroids do not cause abnormal uterine bleeding. At the same time, I will also add all fibroids do not need to come out. So again, imaging M is for malignancy. In a malignancy, you will see a thick or heterogeneous endometrial thickness. And if the patient is postmenopausal, then the endometrial thickness more than 4 millimeter is considered suspicious and needs endometrial sampling. This is a slide of endometrial polyp. As you can see, the measurement there, it's beautifully sitting right in the middle of the uterine cavity, and this is a sagittal view. The next is a picture of a submucous leiomyoma. The entire fibroid is sitting in the uterine cavity, and this is a great example of how a submucous fibroid can cause irregular bleeding. Or sorry, I don't want to use the word irregular because that's very non-specific. I was going to say submucous leiomyoma can cause menorrhagia. This patient would be a perfect candidate for a hysteroscopic resection of fibroid since the fibroid is sitting in the uterine cavity. Additional imaging that you may need will be MRI of the pelvis. So MRI is very diagnostic, highly diagnostic, and has a high sensitivity and specificity for differentiating fibroids from surrounding structures. So I usually do MRI if I have a patient with rapidly enlarging fibroids, or if there is a pelvic mass that we cannot differentiate between a fibroid or an adnexal mass. Many times you will see a big 8 centimeter homogeneous adnexal mass, which could be either a pedunculated fibroid or it could be an adnexal cyst. So an MRI can be very useful in such a situation. Pre-surgical planning. I usually will do an MRI if I'm planning to take a patient to the operating room just for myomectomy, because you want to know exactly where the fibroids are located and what your approach is going to be. Also, if I have a new onset large fibroid, for example, patient who did not have any fibroids before, or she had smaller fibroids, and now we see a big 7 to 8 centimeter fibroid, which is unclear on ultrasound. You want to do MRI to make sure rule out sarcoma and also to localize the fibroid and see any additional pathology. Role of CT scan, only if the ovarian cysts, only if we have additional ovarian cysts or masses and we are worried about ovarian malignancy or worried about lymph node enlargement, then a CT scan can be more sensitive. So what's the role of imaging in the non-structural causes, Cohen? So it's non-structural, so what's going to happen to the imaging? Most likely it's going to be normal. You will see a normal uterus, normal size, no adnexal masses, and the endometrial thickness will be within normal range. So in this case, you will treat the patient as per her symptoms. So in our presentation today, I'm going to just cover the basics, but each condition does require an entire presentation in itself. All right, let's go forth from here. So endometrial sampling, when should you do that? I get this question all the time. So this is the recommendation from ACOG that I put in here. But again, there are some caveats which you can use your own, risk factors and then decide accordingly. So one thing is you want to decide when to do endometrial biopsy versus DNC hysteroscopy. And I can go into that further later. But when do you do endometrial sampling? Age more than 45 years, patient with new onset menorrhagia, then it's recommended. When do you do it in women less than 45 years? If they have those risk factors that we talked about earlier, which are obesity, PCOS, or if they have failed medical management, or if they have history of unopposed estrogen exposure. Believe it or not, sometimes I do get patients who have been on unopposed estrogen for whatever reason, or because they are taking over the counter compounded estrogen creams. Yeah, they're out there. And these patients come in with bleeding. So this is why adequate history is very important, and endometrial sampling is very important. So how do you plan for treatment? Before getting into this, I also just want to quickly talk about when should you do endometrial biopsy versus DNC hysteroscopy. So endometrial biopsy is performed within the office, and you want to make sure you get the right candidate, which means they have had a vaginal delivery and they do not have any cervical fibroid and they have a reasonable pain tolerance. If they've had prior C-sections or if they are nulliparous and have had no vaginal birth, you can counsel them and tell them about the expected pain. We may need to give them preparation with oral misoprostol to soften up the cervix, and then schedule them for office endometrial biopsy. Many of these patients will opt for DNC hysteroscopy under anesthesia because they are not comfortable with the pain. But this is where you need to use your clinical discretion. Treatment planning. Which factors do you need to consider and how do you plan the treatment? So main thing is clinical stability. Now, if the patient is unstable, she needs to be in an emergency room and get IV hydration and possibly get intravenous estrogen for acute control of the dysfunctional uterine bleeding. But other factors to consider would be acute versus chronic bleeding, which means new onset or the patient's always had it, and the desire for future fertility, and what are the underlying medical conditions such as Willebrand's disease or underlying diabetes, which could be a risk factor for PCOS. So you want to make sure you are planning accordingly. I have few patients who have had history of thromboembolism, pulmonary thromboembolism, and are on lifelong anticoagulation. So it is very hard to plan treatment for patients like these because you cannot stop their anticoagulants, period. Acute hemorrhage. So in an acute hemorrhage, again, you want to decide what you're going to do, surgical versus medical management. So this is just an overview of the factors to be considered. So management for patients with puberty, from puberty to 45 years of age. Number one rule is always rule out pregnancy. If you do not mention this in your boards, you will be out right away. So the first thing is you're going to do a urine pregnancy test and you're going to do a serum beta HCG as well. Now this is when you start remembering the causes. The PALM acronym, P is for polyp. So how do you manage a polyp? Hysteroscopic removal. It's just operative hysteroscopy and you remove the polyp through the hysteroscope. A is for adenomyosis. So adenomyosis is endometriosis of the uterus. So there is really nothing surgical you can do except hysterectomy after the patient's done with childbearing and has failed medical management. But before that, we have a lot of things that we can do. Oral contraceptive pills are the first line. And then if they fail, we could do Lupron or Depo-Provera, and then the last resort is hysterectomy. Leiomyomas. Now this is where the poor leiomyomas are blamed the most, but are usually not that significant in terms of the causes of menorrhagia or DUB. So submucous leiomyomas can be removed by hysteroscopic resection, by operative hysteroscope, or by using MyoSure device. I usually restrict this procedure for leiomyomas up to 4 centimeters. More than that, it can take a lot of time. It can lead to more fluid deficit, and it may not be completely successful. Intramural leiomyomas, if they are big and all other causes have been ruled out, then you can consider myomectomy. Now, the route of the myomectomy depends on the surgical skill, surgeon's expertise, the size and position of the leiomyomas, and any prior history of prior surgeries. So, we're not going to jump into that here, but I just wanted to go over when to go for surgical management. M is for malignancy, in which case you are going to refer the patient for GYN oncology for surgical or definitive management. And again, malignancy would have been identified by an endometrial biopsy or pathology from DNC hysteroscopy. So again, same management principles for other things. You want to rule out malignancy. So when you have small fibroids or non-structural causes from the Cohen acronym, you still have to do rule out malignancy and do the same basic workup. So do not skip that if you don't see anything anatomical. So coagulopathy, ovulatory dysfunction, and endometrial causes all warrant the same investigation. So management based on sonographic findings. So I know it's very confusing for a lot of people. In fact, even for me, it took me a great REI or reproductive endocrinology teacher, as well as reading a lot myself, to figure out how to manage and why is endometrial thickening or endometrial lining important in management of dysfunctional uterine bleeding, and what does it mean. So if an endometrial lining is thin, that means less than 5 millimeters. Usually oral contraceptive pills, combination oral contraceptive pills will work great. You can do a taper regimen followed by combination oral pills with a dose of 1.5 by 30 or 1 by 20. So when I'm saying 1.5 by 30, the first number is for ethinyl estradiol and the second number is for the progesterone component, which is levonorgestrel or norgestrel. So initially I write, if a patient is with menorrhagia, initially I do a standard dose like 1.5 by 30, and then once she regulates on this dose, then we can go down to 1 by 20. It depends. You can vary clinically. After experience, you will learn which patient to start on the 1 by 20 pill and which patient to start on the 1.5 by 30 pill. Some of the generic ones here are Apri, which is 1.5 by 30, or Junel or Microgestin. They come in both 1 by 20 or 1.5 by 30. So now if the endometrial thickness is thick or if the patient is bleeding heavy. So remember we talked about ovulatory dysfunction and anovulatory dysfunction. So ovulatory dysfunction means patient is not ovulating regularly. What does that mean? If the patient is not ovulating regularly, that means there is some estrogen progesterone imbalance going on, right? What most commonly seen is anovulatory bleeding, which means there is estrogen buildup. Patient has a period of amenorrhea in which the estrogen keeps rising and keeps building up the lining thicker and thicker, and then either the patient's endometrium cannot keep it anymore, so the patient sheds the lining, and then there's heavy bleeding, which is seen commonly in obesity and PCOS, or the patient's progesterone levels that rise are not high enough, and then the lining is unstable, so it sheds. The whole point is that when the endometrium is thick, then the patient is high in estrogen. So giving combination oral contraceptive pills may not work right away. So you may need to do just the progesterone to control the bleeding because that's what the lining needs at that point. In that case, you consider Provera, 10 milligrams daily for 21 days. You could do megestrone acetate as well. I just do Provera because it's easily available. You could also do Prometrium or micronized progesterone 200 milligrams daily. Um, so you do this, let the lining get under control, let the bleeding stop, and then you repeat the ultrasound post-menstrually after the bleeding has stopped so that you can evaluate the endometrial lining much better and rule out any intrauterine polyps or if the lining actually thinned out. So in the post-menstrual ultrasound, if you still have an evidence of polyp or a heterogeneous endometrial thickness or a submucous fibroid, then you may need a surgical intervention. So please do remember that all this mention and talk of the ET and the lining and stuff is if the patient is in reproductive age group less than age of 45 with no risk factors, and if the patient is young, even though the patient is younger, less than 45, but has risk factors such as obesity and PCOS, you should do endometrial sampling before giving them any hormones. And the reason for that is that if we give progesterone to a patient who is at risk for endometrial hyperplasia or malignancy, we are going to be altering the pathology, and we can miss a cancer or a hyperplasia diagnosis. So, management of acute uterine bleeding or acute AUB. This is when the patient is hemodynamically unstable, and this is done as an inpatient or an emergency room treatment. So we give IV conjugated estrogen, 25 milligrams intravenously every 6 hours, up to 4 doses. Obviously, there are contraindications is active liver disease or history of prior thromboembolism or prior clots or any clotting genetic abnormalities such as factor V latent deficiency or protein CNS deficiency. So you want to make sure that you ruled out all the contraindications. After doing the IV conjugated estrogen, you go on to tapering the oral contraceptive pills. I can explain what a taper regimen looks like. And you could also go into the oral medroxyprogesterone acetate like we talked about earlier. We can also give oral or intravenous tranexamic acid, which is marketed as Listida, but we do have generic tranexamic acid. This comes in, the oral one comes in 500 milligrams 750 milligrams, 2 tablets every 8 hours for 5 days. So you want to make sure that the patient does not have high risks of thromboembolic disorders again, and also the pharmacy will not dispense tranexamic acid along with oral contraceptive pills because they have an alert that shows the high risk of clotting, so they will not dispense it. But I usually always make sure I tell the patient that when you're taking tranexamic acid, it will be during that interval in between the time when you're on the oral contraceptive pill, so that it doesn't increase your risk of thromboembolism. The second thing you don't want to forget is anemia management. So these patients may be anemic, so you want to make sure you give them oral iron. Again, with the oral iron, please make sure you're giving them stool softeners or giving them the preparation of iron which does not cause significant constipation, because otherwise the patients will stop taking it and will continue to be anemic. Some of these patients may even need a blood transfusion. So again, that's a emergency room evaluation and depends on their hemoglobin and hemodynamic status. So, just to go over the contraindications of various treatments, the estrogen containing treatments, for example, the IV conjugated estrogen, as well as the patch or combination oral contraceptive pills. Contraindications are active breast cancer, history of deep venous thrombosis, venous thromboembolism, active liver disease, prolonged immobilization, smokers more than 35 years of age, ischemic heart disease, migraine with aura, valvular heart disease with complications. Um, Progesterone only treatments are medroxyprogesterone acetate or prometrium or depo-provera. The contraindications are active breast cancer and history of deep venous thrombosis and venous thromboembolism and active liver disease are also contraindications for progesterone only. So don't forget that. Tranexamic acid, it's pretty much same as above. Past or current history of DVT, pulmonary embolism, venous thromboembolism, and also acquired impaired color vision. I'm not too sure, and I meant to research this, but I just didn't get around to it. But it is mentioned in their um, contraindications, so I don't know why, though I have to check that. And caution with combination oral contraceptive pills at the same time, as I mentioned previously. Efficacy. So the hormonal management, acute hemorrhage is stopped in 88% of the patients who used combination oral contraceptive pills and 76% with medroxyprogesterone in 3 days median time, medroxyprogesterone or Provera. With tranexamic acid, there is 30 to 55% reduction in blood flow. So please remember that it does not stop the bleeding. It reduces the blood flow by about 30 to 50%, which is exactly what I tell my patients. But that reduction in blood flow helps the patient function and or tide over time to be scheduled for surgical management if needed. It's actually very useful. Long-term management of such patients. So long-term management would be needed for women who have recurring causes such as ovulatory dysfunction or PCOS or puberty menorrhagia. So the key to long-term management of DUB is combination oral contraceptive pills. Um, if the patient doesn't have risk factors and no contraindications, then this is the best thing for management, long-term management for DUB. I mean, not the best thing, I would take that back, but I guess the least invasive um, management option. The, the second and very growing and popular management option is levonorgestrel IUD like Mirena, Skyla, and Kyna. Mirena is for 5 years, Skyla is for 3 years, Kylina is the newer version, which is good for 5 years, and it's skinnier, so it's easier to insert in nulliparous women. Now, in the above, in the levonorgestrel intrauterine systems, you have to consider breakthrough bleeding management because these patients will have regular spotting and bleeding. So, especially with Kylina, because it has a lower dose of levonorgestrel, these patients can sometimes have continuous spotting for months, and we can discuss that later after the slide. You do want to monitor every 6 months if needed, do clinical workup, blood work, and imaging if needed, and then obviously just the clinical evaluation. Please make sure that when you're giving these, doing a levonorgestrel IUD to these people, you're not, if the patient has a submucous fibroid or an endometrial polyp, then I would suggest removing the intracavitary lesion of any kind before putting in the IUD because with a submucous fibroid, the IUD may get distorted or may not stay in the right spot, and with a polyp, the IUD may not be effective. So you want to make sure you are ruling out intrauterine pathology before doing that. And obviously, you also want to make sure that the uterocervical length is the right length. If the uterus or the uterine cavity is more than 10 centimeters in size, I usually limit it to even 8 centimeters. But if it's more than 10, you cannot put an IUD in there. Um, Management of acute hemorrhage. Again, in cases of hematological disorders, this would be puberty menorrhagia mostly. So you're doing hormonal treatment, as we discussed. Um, in von Willebrand disease, you do desmopressin, which is intranasal spray, works wonderfully, but you may need a tertiary level center to get the desmopressin. Factor VIII replacement if it's a factor VIII deficiency, and then von Willebrand factor replacement again if it's a von Willebrand factor deficiency. Um, if patients have bleeding due to platelet dysfunction, you want to make sure you're avoiding non-steroidal anti-inflammatory drugs because they affect platelets, as we know. Long-term regimen, again, even for patients with these hematological disorders, their mainstay of treatment is actually either combination oral contraceptive pills or patch or NuvaRing. I've had patients with very rare, extremely severe bleeding conditions, and then they had to have embolization for bleeding in other sites of their body. But for menorrhagia, NuvaRing worked great. And she's still my patient. She's still doing great. We just need to find out what's going to happen when she gets pregnant. So we will get to that when we get to that. Surgical management. Just to explain this, and I know I went through it before, but just to go over this again. Fibroids only when they're submucous or intramural with submucous component that we need to remove them. So initial treatment or initial management would be hysteroscopic resection, and then, as we discussed before, to decide between open versus laparoscopic myomectomy. The last resort is hysterectomy if the patient is done with childbearing and there are multiple fibroids and everything else has failed. And uterine artery embolization, we should not forget about this excellent option because if the patient has multiple fibroids and has menorrhagia, is sort of perimenopausal, endometrial uterine artery embolization would be a great option for this kind of patient. I usually restrict that option for women who have completed childbearing. However, newer studies are coming out which indicate that UFE or uterine fibroid embolization does not have adverse effects on placentation. I am still hesitant, but I'm going to do more research and maybe I can get more clarity on that. But as of now, restricted to women who are done with childbearing. Surgical management continued for the non-structural causes, such as if there are no fibroids, or if the patient has adenomyosis or just dysfunctional uterine bleeding, which is again like ovulatory dysfunction. Endometrial ablation with radiofrequency or NovaSure is great. That's you put a device inside the uterine cavity, it measures the uterine length and width, and the radiofrequency pulses or the radiofrequency energy burns the lining up to a depth of up to 3 to 5 millimeters. And then after the burning cycle is completed, you just remove the device. It works great, but the side effect of this device is sometimes if there is any endometrial tissue that is left unburned, can cyclically cause a lot of pain and even lead to hematometra sometimes. And you just want to make sure that the procedure is being done properly. And then last resort again is hysterectomy if the patient doesn't respond to any medical management. And even in patients with adenomyosis, you can offer them uterine artery embolization because technically that's what's happening is you're cutting off the blood supply through the uterine artery, so that should work almost like a Lupron or sort of decreasing the blood supply to the uterus can help you relieve pain and bleeding. And it's minimally invasive, so it's worth a try before going for hysterectomy. Um, Conclusion. Again, I just want to do a full overview of the causes because this will really help us go logically through the sequence of how to manage DUB. Polyp, adenomyosis, leiomyoma, malignancy, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not otherwise classified. So I hope the way I kind of split the presentation by causes to evaluation and management, I hope this gave you some clarity. I tried to simplify it as much as I could. The main treatment considerations that you need to think about are: number one, rule out malignancy. Number two is you want to give them age appropriate treatment. Number three, future fertility, because I know we talked a lot about giving patients a combination oral contraceptive pills all the time for ovulatory dysfunction or DUB. But if this patient is trying to get pregnant, then this is the wrong option. So in those cases, you may need to do 3 months or even just a month or two of combination pills to get the bleeding in order, and then start with metformin or ovulation induction, depending on what the patient is suffering from. And then long-term maintenance too, you want to see what the patient will be compliant with, and this is how you come to a mutual decision with the patient as to what will be the best option for the patient. Same thing, underlying medical conditions. Again, if the patient has a coagulation disorder or something, you cannot be doing, you can't even be giving them tranexamic acid. So we need to customize the treatment depending on the patient. Thank you, everyone. And I know this was a really long presentation. And when we did this presentation, I had a few questions from the participants. So I'm actually going to just talk about the questions right now so that we can cover a little more. One of the questions I got was, is Mirena a good option for adenomyosis? So adenomyosis is tricky. These patients have severe cramping dysmenorrhea, and sometimes they will not tolerate the Mirena well because Mirena can act like a foreign body. Even though it will reduce the bleeding, just having a foreign body in the uterus in patients with adenomyosis, they can get severe cramping and may not be able to tolerate Mirena. So usually patients with adenomyosis, I offer them external hormones such as oral contraceptive pills or patch or Lupron or NuvaRing before offering them Mirena. And also, patients with adenomyosis are not a good candidate for endometrial ablation because of the same reason that their main problem is not endometrial lining, their main problem is uterine lining. Their main problem is myometrium. So just by burning the lining, we're not going to fix their problem. Second question that I had was Nexplanon. So Nexplanon has become very common, and we are getting a lot of women with Nexplanon as well as with Kylena coming with continuous spotting bleeding for like months. How do you manage this bleeding? So think about it. The reason this bleeding is happening is because it's very, very thin lining. It's almost like atrophic bleeding because of extremely thin lining because of high progesterone levels. So in this case, they need estrogen support. You can give them estrogen support by either a patch. You can do standard 0.5 milligram or even 0.375 milligram estradiol patch twice weekly, or you can give them oral estradiol 0.5 tablet daily for 3 months. In this case, you can give them unopposed because they already have progesterone in their body. So you don't have to balance out with another progesterone. You could also give them an estrogen dominant birth control pill such as Apri to control the bleeding. because it's easier to get and maybe covered by insurance. But yeah, usually if you give them estrogen support and endometrial support with estrogen for 3 months or even up to 6 months, and when you stop it, they usually do fine. In some cases, we have to remove the Nexplanon or Thylena because the patient just continues to bleed and bleed. And what other questions I had? Um, yeah, I think pretty much I covered most of it. And if you have any other questions or concerns or comments, please feel free to email me. Um, my email is attached to the link, and it's agupta@walkingyn.com. I really appreciate everyone's patience, and I really hope that all this was useful for everyone. Thank you.